Hello everyone. Today we are going to discuss the management of acute severe asthma. So the patient will present to us with severe shortness of breath, and what we need to do is we need to first establish, is this really asthma? So whenever we see a patient who is wheezing, we need to make sure that it is a polyphonic wheeze in order for it to be asthma attack. If the wheeze is monophonic, then the trajectory will change. So the wheeze has to be polyphonic. If it is monophonic, then the differential will change. Since our topic is asthma, so we'll stick to polyphonic today. So the patient came to us with severe shortness of breath, they are wheezing, and the wheeze is polyphonic. So we need to establish whether it is moderate acute asthma, severe acute asthma, or life-threatening acute asthma. So we need to check the severity. What is the severity? So we'll discuss a few things that will clear this concept. First thing is, if it is moderate, then it has to be tachypnea, obviously. Respiratory rate has to be 20 to 25. PEFR, which is very important, PEFR has to be 50 to 75. So this will be moderate acute asthma. If it is severe, then PEFR has to be 33 to 50% best. Respiratory rate has to be more than 25 per minute. Their heart rate has to be more than 110 per minute, and the patient will be showing inability to complete their sentences. This is very important. If the patient is unable to complete their sentence, their PEFR is 30 to 50%, respiratory rate is more than 25, and heart rate is more than 110, then it is severe asthma. Now we need to establish whether this patient is exhibiting any signs of life-threatening asthma. Then this patient has to be confused. This patient has to be exhausted. So what do I mean by exhausted? Is the patient will be using accessory muscles. SpO2, it may be less than 92% on room air. The chest may be silent. If the chest is silent, we need to call ICU. This patient may be needing NIV, non-invasive ventilation, or intubation. We'll discuss who needs NIV and who needs intubation. So to summarize, after we have established this patient is having acute severe asthma, we need to categorize if it is moderate, severe, or life-threatening asthma. So once we're done with this, we need to move to the next step. The next step is assessment of A, B, C, D, E. So first check the airways. V's we already discussed. It has to be polyphonic V's, and we need to make sure there is no foreign body and there is no other cause. So if the chest is silent, we need to be alert, we need to be very careful, because this patient may be having near fatal asthma attack. So the first thing is, if the patient needed oxygen, we need to give them oxygen. Then nebulize. Nebulize this patient with Ventolin, salbutamol. Very important. Although it causes tachycardia, but this is very important because it will open up the airways. So salbutamol and then ipratropium. Ipratropium bromide plus salbutamol these two are very important. And the next thing is corticosteroids. Usually we give IV hydrocortisone 100 milligrams, but the recent NICE guidelines, they say you can give oral prednisolone 40 to 50 milligrams. No difference. There's no difference in efficacy, and you can give oral. So either IV hydrocortisone or oral prednisolone. So if the patient is still not improving, what do we need to do? If the patient is still not improving, we need to give them magnesium sulfate, MgSO4, IV bolus over 20 minutes, very slow. Sometimes people give it very fast, it can cause hypotension. Be very careful. So we need to give them magnesium sulfate. If the patient is still not responding, what do we need to do? This is a very important question. So usually junior doctors, they know till magnesium sulfate. The next step is very important to know. And the next step is the decision between non-invasive ventilation and intubation. Who needs an IV and who needs intubation? See, it is very important to know that non-invasive ventilation is not a substitute for definitive airway management in a patient who is failing. So carefully select the patients who are awake, cooperative. Very important. The patient has to be awake and cooperative, otherwise you will not be able to use an IV, because you have to protect their airways, and they have to be hemodynamically stable. They have to be stable, and they have to be spontaneously ventilating. Spontaneously ventilating. Not severely acidotic. Not severely acidotic. If you see a patient who has either normal PCO2 on ABGs, or they have increased PCO2. It's a very bad sign, because normally the patients of asthma, they are hyperventilating. So once a patient hyperventilates, what do? They wash out carbon dioxide. If someone is not washing out carbon dioxide, means their respiratory muscles are exhausted. They are having labored breathing, and they are almost collapsing. So what do we need to do in this case? Prepare for ICU admission. This is very important, so be very vigilant and remember all these steps. So once we know the patient is awake, cooperative, hemodynamically stable, we can give them a trial of non-invasive ventilation. So the next step is, when do we escalate? From here, we escalate when there is progressive hypercapnia, when there is severe exhaustion, when the conscious level is reduced, when the patient is unable to cooperate and unable to protect their airway. So it's then we decide about intubation. So from here, you need to know one more thing. The goal is to allow adequate expiratory time and minimize dynamic hyperinflation. What do I mean by this? The goal is to reduce the respiratory rate, give the patient adequate expiratory time, avoid excessive minute ventilation, and monitor for auto peep. And also hyperinflation. An important point here is that sometimes permissive hypercapnia can be acceptable sometimes when it is appropriate. And remember, intubation is also a high risk procedure. Why? Because before intubation, the patient generates very negative intrathoracic pressure to maintain ventilation. After induction, this scenario changes. PEEP, or positive pressure ventilation, combined with severe dynamic hyperinflation, can markedly reduce venous return. And when the venous return is reduced, what happens? The patient can collapse. So be very careful. So the important take home message is, whenever you see a patient with asthma, first observe, is the patient cyanotic, having labored breathing, what is their conscious level, What are the examination findings? For example, what are the auscultation findings? Look for V's and then calculate their respiratory rate, check their pulse, blood pressure, PEFR, peak expiratory flow rate. Do not waste a lot of time on checking this thing. If the patient is confused, they are not cooperating, you don't have to necessarily obtain PEFR in order to proceed, because the ultimate target is to save the patient rather than fill the forms. We are here to save the patient. So I hope you enjoyed these points and please give me the feedback. Thank you very much.